I do think that especially psychodynamically oriented therapists, but really any therapists that work with people with real serious problems that involve their personality, the complexity of their life, genuine therapists who want to help people over the long term from any theoretical orientation, have been troubled that there's been a kind of paradigm shift over the past 20 or 30 years in which psychotherapy used to be thought of as a healing relationship. And within that relationship, you might use a number of different techniques, but the emphasis was on the relationship and on the therapist as a healer. And for many reasons, in recent decades, psychotherapy has been kind of silently reconfigured as a set of techniques to be applied to discrete medical disorder categories. And that happened for a number of reasons. For example, the drug companies, especially in the United States, were claiming that their medications worked better than anything else for depressive and anxiety disorders. And so many researchers here began testing that. And to do research on something like that, you have to delineate a problem. It has to be a specific disorder that you're getting subjects who have that kind of problem. You have to take measures at the beginning that are objective. You have to manualize what you do. You have to take measures at the end, and it has to be time limited because your grant is going to run out, or you want to get your publications. And so then you evaluate it based on changes in symptoms that are observable at the end. And by using that model, people like David Barlow, for example, a very eminent researcher, demonstrated that psychotherapies are as effective for those conditions as medications are. So we were all grateful to him, but in the process of sort of accepting the paradigm of the drug company and the paradigm of the researcher challenging the drug company, we kind of slowly started talking about psychotherapy as a process where you should have a discrete disorder category. You should measure it at the beginning. You should do a set of short-term manualized interventions. You should evaluate it based on symptomatic change in the short term. And those things don't make any sense to people who have been working as therapists for a long time. What people come for is not, it's true that relieving symptoms is very valuable and people are grateful for that. But in real psychotherapy, including cognitive behavioral therapies, people have always come for things that are a little bit more general than that. Not just, I want to feel less depressed, but I want to understand myself better. I want not to be panicky. I want to be able to manage my emotions better. I want to know better who I am. I want some improvement in my general self-esteem. I want to be able to accept things that I can't change. I want to have a range of ways of reacting to things rather than always going on automatic pilot with my one method of coping. There are all kinds of ways in which people look for improvement in a more general way. And in psychotherapy, people can get temporarily more anxious, for example, if they're trying out new behavior for the first time. So they might look worse in the short run, or they might look more depressed as they're finally grieving something that they've been using denial about for years. For a while, the arc of therapy goes forward, people go up, but it's an up and down process. And partly for political reasons and commercial reasons, there's been a tremendous effort to think of psychotherapy as a commodity and therapists as a provider of that commodity. So there's tremendous pressures on us as therapists to see ourselves as technicians applying treatments to particular disorders rather than as healers whose expertise is in relationship and personality issues and complexities. who offer a relationship to a complex person. And it's kind of bizarre that we've reframed psychotherapy that way, since there's huge empirical data showing that by far the vast amount of the variance in psychotherapy outcome is accounted for not by the brand name of the type of therapy, the technique that you apply, but by personality factors and relationship factors. They're the things that explain change in psychotherapy. So we're not really studying those the way we should. Instead, we're studying all these things that are easy to research according to a particular randomized controlled trial method of looking at what technique applies to what disorder. So I think we have to address this politically, as well as trying to speak the truth to our scientist colleagues, our researcher colleagues. We have to know the research, and we have to argue based on the evidence. And I think there are many arguments that would preserve traditional psychotherapy based on empirical evidence. The fact that the Diagnostic and Statistical Manual of Mental Disorders makes an incredible amount of money for the American Psychiatric Association means that there's, of course, resistance to construing psychotherapy as anything other than using these disorder categories as the main concepts within which everybody thinks about change and growth in human beings. So prevention doesn't get talked about as much, development doesn't get talked about as much, ways of intervening to make people healthier in a general way doesn't get talked about as much. It's sort of, how much money can you save me next week? And a lot of my career has been trying to be the voice of the therapist, speaking back to some of these pressures. We have pretty impressive data coming out of Germany and some parts of Scandinavia that the more people are in psychotherapy, the more money is actually saved in the long run. There are studies that Susan Lazar has put together in a book called Psychotherapy is Worth It, that are all empirical studies of how the more frequently and the longer you are in psychotherapy, the less likely you are to develop a substance use disorder, to go to jail, to take sick days from work, to get physical illnesses. We have a lot of data on that, and we need a lot more. So I would wish that researchers would be studying this further. But unfortunately, politicians and insurance companies want to see how much you've saved us now. They're not looking at, does this really save the culture a tremendous amount of money and trouble 20 years from now? Therapists aren't really lobbyists. Speaking as a therapist myself, I just want to be able to sit in my office and try to help people. I'm not a fighter. I don't want to be on the barricades. I don't have the temperament to lobby and go out there. I would much rather teach what I'm good at than defend what I do to people who are raising all kinds of questions about it. But in these times, we have to defend what we do. We have to learn some way of speaking truth to power. Psychoanalysis as a technique has never been something that I was nearly as excited about as I am about psychoanalysis as a way of understanding the depth of people. I had that myself. It was transformative for my own life in countless ways. But what I'm most interested in preserving is not necessarily that particular model as the model of thinking in depth about personality, subjectivity, the nuances of differences between people. If you're going to say that we only support treatments that have demonstrated statistical averages that they're effective, then the problem there is, even with physical problems, if your doctor knows you well enough that they know that you have a sort of idiosyncratic reaction to a medication that on the bell curve most people respond well to, your doctor will be at risk if they prescribe something else if they can be told, I'm sorry, best practices dictate that you do it this way. So it's the what some people have called the industrialization of mental health care that's troubling me more than the particular theoretical orientation. Experienced cognitive behavioral therapists are developing ways of thinking about people that are very similar to the ways that people who are trained analytically have thought about them. They have different language, they have different metaphors, different categories, but it's the same concepts. Neuroscientists are finding ways of talking about things that we've talked about only through hypothetical constructs before. So I don't think the argument that we have to make is about that, psychoanalysis is the only way to do anything. It's much more that we have to keep a sensibility alive that involves respect for individual subjectivity, individual suffering, the complexity of things, the humility involved in approaching things as if we don't know the answer. It's going to take us a while before we can figure out with the patient what will be the most helpful thing to do here, as opposed to, well, the evidence says that for this disorder you apply this technique. Why aren't you doing it? If you're working with an oppositional person, it's good to know that the more you urge something on them, the less likely they are to do it. Even if you're only medicating, it's good to know something about why people might resist that or what attitudes they might have toward authority. If you want them just even to take their medicine, you have to know something about how to make a relationship with them that takes into account their individuality and their probable reaction to you based on their history. Now, if there really is wisdom in any training tradition, you would expect to see that if it gets devalued, it'll be reinvented by the next generation of people, and I think I keep seeing that in the field of psychotherapy. It's frustrating sometimes because you wish that some of the wisdom could be handed down a little faster without people having to reject it wholesale and then rediscover it in some other form. And so increasingly, I get phone calls from people who say, I have social phobia, can you fix it? As opposed to, I find myself being a shy person and I'd like to understand more about that and change it. It's a very different paradigm there. Nothing is all good or all bad. There is some way in which I think it has reduced shame to think of certain kinds of things as freestanding disorders that you happen to have come down with.
Addiction.
Yes, very much. So there's a positive side of that. But the negative side is that people hope that they can just isolate a particular problem, learn a strategy for solving it, and that's going to fix everything. When in fact they often need to look at their lives. Are they living a livable life? Are they able to love? Are they able to work? Are they able to enjoy? Are they able to feel joy and playfulness? Are they feeling the full range of affects without anxiety? Are they not having to dissociate when they're stressed? All kinds of overall issues. That's probably my next book, is I want to write a book on overall mental health as opposed to just the relief of symptomatically defined disorders. We seem to be in a fairly reactive position now, as we are constantly fighting off the idea that we should be able to do miracles in successions. For the poor and for working class people, it's no longer possible under most circumstances to get a relationship with a therapist who's going to be ordinarily devoted to you. When I talk to therapists who are working sometimes with people who are just barely hanging on to their sanity, the only thing that's keeping them out of the hospital is they've had this therapist for 20 years. Now, some people who are not therapists look at that and say, well, obviously it doesn't work. They're still seeing you after 20 years. Well, if the alternative is that they'd be crazy in a hospital or committed a crime and are rotting in a jail somewhere, that's very minimally expensive compared to that. So you could make an economic argument there. I think that's important to make, but there's just also the human argument that we are creatures who attach and who are designed to flourish in relationship. And therapists are not like your hairdresser, although hairdressers are sometimes therapists too. But they're not just interchangeable. It's not just, if you didn't fix this with this one after 5 sessions, go on to the next one. It's a relationship. And you do have to internalize it. You need to internalize voices that talk back to the voices you internalize that are getting you in trouble.